we have a large component of interstitial cystitis, which is undiagnosed or underdiagnosed infections.
So I wanted to ask you a couple of questions about recurrent UTI and IC treatment and how you work with your patients. The first question is, do you have any general advice for people whose symptoms disappear when they take antibiotics and then return again a short time later?
IC is changing. The field around IC is changing. I believe the thought leaders in interstitial cystitis and urology and urogynecology and women's health have taken on the notion that we have a large component of interstitial cystitis, which is undiagnosed or underdiagnosed infections.
Mm-hmm.
In my own practice, that was one of the first subset of patients that I discovered the benefits of the next generation sequencing technology, because the patients acted as if they had an infection on top of their interstitial cystitis.
Right.
They complained of worsening symptoms when they have a urinary tract infection and knew exactly what those symptoms were like, but then the failure of the traditional cultures to be able to deliver results that we could use to treat successfully was a big part of that. And so those were among the most helpful. And I think at least a half a dozen of them at the very beginning, which sold me quickly on next generation sequencing,
Mm-hmm.
particularly in patients for whom infection symptoms on top of another entity could be problematic. So I would say, and I'm getting stronger by the day from the standpoint of my emphasis on this, and that is, if you have an infection or a history of infections and you think you have an infection, or if you have a chronic condition which is exacerbated by an infection on top of it, complicating it, then I would demand your doctor learn how to do next generation sequencing and run that test.
Mm-hmm.
Because you will find, in my case, probably 80 to 90% of the patients. Indeed, I was interviewed last week by a lab asking for clinical relevance. It's basically a clinical lab meeting and an association of clinical laboratories.
Mm-hmm.
And they wanted a clinician to talk about clinical significance. And I told them that we really have to rethink what we call an infection these days. And limitations in technology are the most important thing.
Mm-hmm. So you mentioned people that have been diagnosed with IC that have an infection on top of their IC, which is the language that we hear a lot. If they have been culturing negative and then sometimes they culture positive, which is when they say they have the infection, do you think the whole set of their symptoms could actually be caused by infection, or that they do have a UTI on top of whatever else is happening?
I think the simplest thing to do is to identify and treat. And if you identify with next generation sequencing, you've done everything you can. Now, some of those are frustrating in that even then the NGS is negative. However, I just took a lady to the operating room last week, and we were going to do biopsies of her lesions because we talked about that. And it turned out that she actually had an ulcer, and the ulcer was positive, and we sent that for tissue analysis, and that showed the infection. So I'm convinced that IC is probably either bacteria or bacterial products buried under the surface, much like acne is, or much like some other cellulitis is, where you really don't have the infection on the surface. There's not there's not an abscess or a pustule or something like that. There's a medical term, but big round pocket of infection, or like a pimple is a pustule, is a pimple, the classic whitehead. So you see these in the bladder on endoscopy, and you say, well, that's got to be something. That's got to be infection. So my goal is to biopsy as many as I can. Now, good news, bad news. Bad news is I'm not finding that many. Good news is because I'm doing the microgens ahead of time, finding them and treating them, and their findings on endoscopy are less pronounced. But I'm still seeing the occasional pimply bladder, as I call it, and I'm going to start biopsying those and sending them. And I dollars to dimes, or these pounds to pence. Is that what you say there?
Yeah, I guess so.
Pounds to pence.
Mm-hmm.
it's going to be an infection.
Okay. And if you do find infection in an IC patient, is the treatment the same as that you would use for a recurrent UTI patient?
So I had a brilliant urogynecologist talk about female pelvic floor issues, and the notion of physiologic pelvic floor dysfunction, like from prolapse or hypertonicity, was one corner of the diamond. The other was pure IC. The other was pure infection, and the other was pure, what am I thinking? Oh, overactive bladder, neurological overactive bladder. So he formed this sort of diamond. Can you see that? This sort of diamond, and at the corners were these. And his point was that every woman is somewhere in there, you know, who's had these conditions before. They're not pure pelvic floor, pure IC. So if you think of this as a sort of a constellation of entities that contributes one versus the other, and sure, the pelvic floor may manifest if you've had 10 infections in a row and your IC is flaring and your overactive bladder, you've had a rough week with diet or something. So I tend to think of it this way. So every time I see a woman who's flaring, whatever her, and that means even if she comes in as pure overactive bladder, I do this thing. Could this be the other three? And so by not treating all four of those at once, you're really not going to get the patient improved as fast as you possibly can. So that's sense. When you said that, I said, yeah, I've got to do that, because she's probably going to get a boost in her overactive bladder medication, maybe interstitial cystitis therapy enhancement, maybe a referral back to the physical therapist or whatever helped her in the past. So that's how I approach that. It'd be great to say that they all got better just with antibiotics, but I can't say that.
Yeah, I'm sure. What's your opinion on long-term full-dose antibiotics, like the protocol that is often used in the UK?
I am changing. I was a big fan of suppressive antibiotics in the past. Many times that was all we had. The problem is if you're dealing with inadequate information or misinformation or negative cultures or inaccurate cultures, and you put somebody on a long-term antibiotics, you're basically calling this a therapeutic endpoint. And you're saying, I'm going to be satisfied with clinical outcomes. And obviously that's okay, if it's okay. And that's not glib. The bottom line is that many times doctors, you're okay. I got you on the, look, the culture says you're on the right antibiotic, 90 days, see you, and you're not good, and you're not happy, and you're coming in telling me that your symptoms are worse. So my experience with the refractory recurrent urinary tract infection patients is that they weren't doing well. And I just didn't have anything. Either I gave up because I didn't have anything else to offer, or that I asked them to live with their symptoms, and we kept jumping ahead, trying to stay one ahead of the next antibiotic. And I would say that that's okay as long as you use the latest technology to identify what organisms are there. But you're good. Next generation sequencing is better identifying. It doesn't do anything about bacterial resistance, because microorganisms are smart, and they don't like being found out. They like to get away with their little madness. And so my opinion is that it would be ideal to use a combination of prevention, a combination of shorter interventions, a combination of antimicrobials that aren't antibiotics, and sort of an overall program of health that is better than that. Now, if you get to the point where you've tried all that and there's nothing else but a daily single antibiotic, sure, I still do that.
Okay. And what about bladder installations? Do you ever recommend those for your patients? Antibiotic bladder installations, that is.
And most of the ones that I've had to do are patients with complicated urinary tract infections from either neurologically mediated issues, retention due to spinal cord injury, multiple sclerosis, stroke, things like that, or they have chronic indwelling catheters or something, some complicated urinary tract history where I really don't have any choice. I haven't had that many patients benefit from bladder installations, and the invasiveness of it, in order to put a catheter in like once or twice a week, and instill the bladder. Typically, I will add antibiotics in a patient with an IC flare. I found that helps.
Okay.
I also add antibiotics to my Botox injections for the patients with overactive bladder, because I feel the particular aminoglycoside antibiotic, I think it helps prolong the benefit of the Botox. But there are installations in patients that can feel and have to catheterize themselves. They're uncomfortable, and also a chance for infection if not done correctly. So.
Yeah, sure. And what about bladder fulguration? Do you ever use that technique, and can you briefly explain what it is?
So do I look that old, Melissa? I mean, I'm just kidding. So the older urologists, and there may be a place for that. There are, everything that's old is new again. And the newer fulguration of the pseudomembranous cystitis and the acne of the bladder that I called earlier, the cystitis cystica, the fulguration of that, I can see that can be beneficial. I don't do it. I feel like the tools are just not there to define that. We don't really know what that is. And scarring can happen anytime. It can happen the first time. I've had a patient get a urethral stricture, a female, which is rare to get a urethral stricture, from a single catheterization during her epidural during her delivery. And so the bladder mucosa, the bladder lining, is a very delicate thing, especially in somebody who's had recurrent infections and IC and all these other irritative issues.
Yeah.
Why nuclear them with thermal energy or laser energy? I don't see it. I don't see it.
Okay, fair enough. So what is your general approach to diagnosing and treating recurrent UTI?
But again, when you have a referral practice like mine, you already have gotten 5 to 15 negative cultures or useless cultures or cultures that showed something, but it was not the right thing to treat. So why waste my time with something like that? So the answer is, sure, the rare case where I get a next generation sequencing naive patient, I'll probably go through some traditional cultures, or a PCR, polymerase chain reaction, is the next sort of in between traditional cultures and next generation sequencing. But that's so rare these days that it's probably 1 in 100 patients. So I go straight to next generation sequencing. I look at the organisms that show in the distribution. I'm very specific about how the specimen is delivered, because if they just finished antibiotics, they're still on antibiotics, it's useless. In fact, 4 days is probably about the minimum to be able to get me meaningful information. And then once I see the organisms, I decide which way to treat. And I try to do, because this is new information most of the time. And by the way, the question was asked during that presentation last week, how many are negative from the outset? How many are, what they said, how many are negative or not helpful or something? It's a contaminant or something. And that number in our now database of over 800 is 8%. And if I kind of threw out the ones that were too soon, I bet the number's even lower. So that's a big number of goodness in your initial diagnosis. Now, does that mean I took 92% of patients with recurrent UTIs, I did their first next generation sequencing, and I cured them in 10 days of antibiotics? Well, no, because again, this is a really tough disease with all sorts of multiple contributing factors. And so under those circumstances, that's what I start with. I treat it. I try to do a shorter course because I just want to see what treating the correct organism does. And then we observe. Again, the whole notion of what is an eradication of an infection these days is changing, because a negative culture means nothing to me. And I can't tell you that getting rid of the organism on the next generation sequencing is the goal either, because often that's elusive. You can get decrease in the reads, which are just sort of the DNA, the copies of the DNA, the machine reads and things like that. So I use decrease in reads. If I don't get any decrease in reads, even if it was sensitive by the recommendations of the panel, I think that's a failure. If a patient had no symptom and I didn't decrease the reads at all on the next generation sequencing, would I consider myself a success? No, that's not enough. I think that the next generation sequencing is so precise that it's really not appropriate to say that we've done anything without that. So that's kind of how I do it. And then we just observe and we repeat and we treat and we try these other things that we talked about with prevention in between once we know we've gotten rid of what was there. And then if we have to, we keep on longer courses of antibiotic.
Okay. And what's the difference between that kind of treatment and how you would approach chronic prostatitis in a male?
So again, as my therapy evolved, I saw men for this refractory, and I have a big referral practice for this, a huge referral practice for this. And I just want to reemphasize that often chronic prostatitis is a infection that's passed between couples, between members of a couple, because the prostatitis lives in this, the semen is the representative, and that's the specimen I get. At the beginning, I started out getting urine specimens in the guys. That was helpful, but not that. And then I started doing this so-called prostate massage, which they hate. But, you know, men need some torture just like women get every time they go to the doctor. So I'm just kidding. But guys are, you know, they're pretty much weenies, and they don't really much put up with that. But the bottom line is the prostate massage and then having the patient void in a cup afterwards was my next step, because that's what all the book says to do. And I know there's a particular urologist that thinks that that's the way to go. I have not found that helpful at all. A semen specimen, if the patient can't produce a semen, because that comes from the prostate and the seminal vesicles, that's where the infection lies. So getting that specimen and sending it is absolutely essential as far as I'm concerned in making that diagnosis. And the same thing with men is that you've got to treat first and see, because most of the time this has never been discovered. So I'm getting a brand new organism that's never been treated, many times with that antibiotic, sometimes a combination of antibiotics for more than one organism, and then see what happens. Now the prostate has poor antibiotic penetration. It's difficult to eradicate infections, so it's important to treat for longer courses than you would say for a female UTI. Quite honestly, there's no such thing as a simple UTI in a male. They tend to be almost all complicated when they come see me. So that's my practice with that. And my success has been good. I would say people are coming to see me for that reason. We even are doing something quite exciting about doing what's known as intraprostatic injections of antibiotics.
I was going to ask about that.
That are very, very refractory, and we've had some good success. We now have used a transperineal approach, meaning we don't have to go through the rectum to the rear end, which really cuts down risk. And this transperineal approach with ultrasound guidance and injecting into the prostate is very exciting, because I believe a lot of these patients that just couldn't be helped. I have anecdote after anecdote of male patients that just were miserable, couldn't work, couldn't function, quite honestly. And everybody called them the male version of chronic pelvic pain. And no, that wasn't it.
We actually hear from quite a few people in that situation, which is why this question has come up. And it does seem a difficult thing to treat.
Thank you. Yes, it is. It is very difficult.
So you said that you've had some good success with that. Do people with recurrent UTI actually recover? Do you have patients that have recovered from this and are well now?
I've been doing next generation sequencing 3.5 years. And I will tell you that the detection is excellent. There's far superior detection of infections at a much more accurate rate than any time ever before in my career. Am I eradicating infection lifelong because of that new technology? Honestly, Melissa, I don't know yet. I don't know yet. There are those for whom I need to go back and look at my success rate and document that. That is something I really haven't, because it's been almost so, we're so thrilled to have this new tool for detection. It's hard to say, okay, let's not throw out the baby with the bathwater and criticize results when we never had anything like this before. I know it's better. I know there are people for whom the impact on their health and the quality of life is improved. They come into my office every day and hug me before COVID. And I've got anecdote after anecdote, as I said, of patients for whom this is a lifesaver, a game changer, and a quality of life saver. And for that reason, I would say that yes, there is a chance for cure. There is a chance for certainly diminishment in impact on quality of life.
Okay, so we have another question from a couple of members of our audience, which is, could a foreign object in the body, such as a breast implant or vaginal mesh, actually be contributing to recurrent UTIs?
So this is a frequent question, and the answer is dependent upon the type of foreign body and where it is, and has there been any incidence of infection before of that implanted material.
Mm-hmm.
The issue with, say, for instance, a eroded vaginal mesh that's unequivocal. Yes, absolutely, that could contribute. That's a simple answer to that one. The answer to a foreign body, such as, say, for instance, in an auto accident, a piece of metal or something like that, and there's a foreign body that may be impacting the mechanics of an organ. Yes, absolutely. That's another easy one. But when you get to things like breast implants, vaginal mesh implants that are functioning well, it's a little bit more tricky to say that there's cause and effect. We know that there's an immune system boost to the foreign implant, even in ones that have not caused the patient any problem whatsoever. You've had it in for years, you don't even know it's there, and you remove them, you see this sort of inflammatory rind around it, inflammatory peel around it that the body has walled off. If you send that to the pathologist, there's all sorts of inflammatory cells and things, white cells in reaction. And I do neurostimulator implants, so I've removed these and I've seen that, and I've seen the tissue as it comes out. And so I think that it's probably a combination of local factors that create a pro-inflammatory response that weakens the immune system. And the breast implant surgeons would tell you that that's not the case. They feel like they're sort of the pariahs now in the surgical field. But the bottom line is that we've had enough patients with these histories of had this condition, it was really bad, or it was worse, got my foreign body removed, my condition is better. So to me, that is that sort of anecdotal evidence all of us docs in the era of COVID have learned to pay attention to, is that trust our own instincts about a patient, and finally listening to people. It's like, my infections are fewer, it was out. There's a reason for that. There's a reason.
So if people would like to make an appointment to see you, are you actually taking on new patients at the moment?
Yes, I am. Yes, I am. And I can.
And for people that can't see you, do you have advice for them on how they can speak to their own doctor about this problem and how they can move forward?
Perhaps we should include some of the excerpts from this discussion about my experience with the next generation sequencing, my protocols. That's not to say mine is the right way. I'm very specific in how my practice evolved. My practice is a fairly unusual urology practice with all these different types of patient populations that have merged to make next generation sequencing quite important for me, essential. But on On the other hand, I've got a lot of experience and would be glad to share it with their providers.